moving on here are my disclosures, none relevant to this talk. And just to highlight that I think the definition of your case mix is always very important, but particularly in a very critically ill population. And in this particular circumstance, we're talking about patients getting ECMO, or also called ECLS, or extracorporeal life support, in the context of ongoing CPR at that time. And the reason I bring this up is if you're looking around at the literature, sometimes this is actually a little bit of a mixed bag. So this is one study that I've seen cited with an international registry of, quote, e-CPR patients with a overall survival of 29%, which sounds really not bad. They were looking for trends over time, but if you look closer, you note that their mean arterial blood pressure pre-e-CPR was actually about 56 millimeters of mercury. And looking further into the patient population, many of these patients were admitted to the hospital for multiple hours before being placed on ECMO. And so really they're referring to patients who receive ECMO in the context of their overall resuscitation and not the ongoing CPR patient. And so I think that distinction is important when we're looking at outcomes. Of course, patient selection is critically important in a number of the studies that we look at. I think last presentation highlighted a few that have shown really excellent, pretty good, promising outcomes. This was one of the more exciting ones from University of Minnesota, where they had 45% survival to hospital discharge, which is obviously very exciting in a patient population with really certain death without this kind of level of care. I think just to highlight, though, all of these are small numbers, and the exclusion criteria that each program applies, as was highlighted, really is pretty pertinent once you're talking about 72 patients altogether that were transported by EMS and initially considered for this protocol, even excluding 10 really has some important implications in addition to all the others that really aren't going to be included here. And so while the survival rates with favorable neurologic outcome are really quite exciting, we have to take into account all the patients here that get pushed to the right. We similarly had looked at doing this and applying at our own county hospital. So a little background about Harborview. This is the county hospital in the level 1 trauma center in a 5-state region in the northwest corner of the country here. It's affiliated with the University of Washington Center as well. And we are fortunate to have a robust pre-hospital system of care where the overall survival of neurologically intact patients who presented with VT or VF and were brought to the hospital with attempted resuscitation was 60% in the 3 years prior to this. If we looked further at our PEA patients, and this is small to see, but 31% of those folks did survive with neurologically intact outcomes, so that's pretty decent. But that was only 8% if we're looking at the asystole population. And so they formulated a pretty comprehensive protocol, but looking at our out-of-hospital or patients arresting in the emergency department on arrival as brought in to focus in on those we're considering for ECMO. We were targeting, again, patients with initial rhythm of VT or VF, including those between the ages of 12 and 65 were included. We do get some pediatric patients there. But we're looking at including patients with an initial rhythm of PEA if there was an additional reversible cause suspected, like massive PE or toxin ingestion, as well as environmental hypothermia, typically prolonged exposure to Puget Sound in our region. Also, those patients had a time of dispatch to the emergency department arrival of less than 60 minutes and were excluded for asystole unless that was in the context of profound hypothermia. We also did not include patients that had a known life-limiting illness like profound cirrhosis or very bad COPD that was well documented. In addition to that, patients that were down for more than 60 minutes or had low end-tidal CO2 despite over 20 minutes of resuscitation were thought not to be good candidates, and so basically took 2 out of 3 of those, including bedside ultrasound showing basically cardiac standstill. In addition to that, the attending MD had some jurisdiction over that as well. So we got that program going and for about over a year and a half, and this is one such case. Is a 56-year-old gentleman who was found down at home. Later we learned he'd stepped outside to have a cigarette and collapsed in front of his friends. So EMS was called and provided emergency services, including 6 shocks en route to the hospital, and he did have intermittent ROSC along the way with that. He was directly transferred to the cath lab. As a result, we didn't have a EKG, but because of the refractory VF, he was a direct cath lab transfer and was in PEA actually on arrival of the cath lab team. So he was placed emergently on VA ECMO in the lab. This is his initial rhythm strip there. And as you can see on his angiogram, there is indeed a missing LAD. So he underwent a procedure after cannulation. He had 3.025 stents placed in the LAD. On IVUS, it looked like the distal vessel, which is obviously a quite suboptimal result, was thought to be just poor flow, likely high thrombus burden in this late presentation from a gentleman potentially, but also just, diffuse vessel spasm in the context of pressors. Now, he had refractory hypotension, so a decision was made to stop here, kind of look towards other issues that might be going on with this increasing pressure requirement. You guys saw a nice video of the Lucas device, which we also use. But just to highlight some of the complications that can happen in this population, this gentleman was noted to have a distended abdomen. They proceeded with emergent XLAP at the bedside in the ICU. He was found to have a grade 3 liver laceration with really ongoing high volume transfusion dependence, and unfortunately had persistent arrhythmia, was requiring the massive transfusion protocol support, and so subsequently died that day in the ICU in consultation with his family. So bring this up just to highlight kind of all the other issues, even if you get a good technical procedural result, which this one wasn't great, but these patients have a lot of issues, and we had a number of those that did die related to bleeding complications from this. So I think the mechanical CPR, especially when prolonged, is not benign. Some of the other issues we ran into were some indication creep. It was maybe an asystole initial presentation and someone thought they saw VF in the middle of long resuscitation. A lot of this information is very garbled as you're getting these calls at 3 in the morning. So out of 53 activations that we had over about a year and a half, 19 were cannulated, 12 of which were VT-VF. I mentioned we're doing quite a few for hypothermia as well. This is somewhat of a typo, so not to be misleading. 4% survival at the hospital discharges these 2 patients out of the 53 activations. So if we're just looking at the VT-VF population, that's 16%, obviously very small numbers. And if we included the hypothermia patients, of which a number of which did quite well, also pretty selected, that's up to 30%. And so I think just to bring it back to the fact that definition really matters with all of these. I mentioned that bleeding complications were the cause of death in a number of patients. We also saw some ischemic complications related to cannulation, and anoxic brain injury, of course, is always a concern. Just in the interest of time, I'll quickly go through a couple other things that have been cited, including the consent of complexity of care for this population. We don't know these patients. You're talking to a long-lost brother who might be imagining this type of care, but they come into the ICU and find this and say, my loved one wouldn't really ever want this type of care. Also, cost is an issue. In the U.S., that's part of the conversation, of course, as well. I found one cost-effectiveness study that looked at e-CPR in Australia, which had a pretty decent rate for quality-adjusted life year rates in terms of the literature. But again, patient selection really matters. A lot of these were inpatient arrests, and they considered cannulation after 10 minutes or ROSC, and had very excellent neurologic outcomes. So it's hard to apply all these in such a messy population. One other note is that reimbursement changes to ECLS are going to potentially affect hospital care patterns to some degree. I hope not. We don't want costs to be driving these things, but central VA ECMO, the national average of reimbursement is over $100,000. Apologize, this is a little blurry, but for just peripheral VA ECMO alone, that's dropped down to about $8,000. And so in this one recent abstract, they noted a potential net loss based off these calculations of over $3 million at one site. In addition to that, these care teams are the same group responding to shock team activations or caring for critically ill patients, and so it's easy for this group to get pulled in a number of directions. Obviously, we have a lot of urgent patients to attend to. So is e-CPR futile? Well, I'll say yes, except in highly selected patients, and obviously our goal is to find those and do a better job of applying those resources so that we're not, in retrospect, looking more like these guys. Each patient population carries its own set of implications. And with our own experience, I think ongoing quality improvement did help us reduce complications, in particular access-related and care up in the ICU, and so that ongoing internal review is really important. So thank you very much for your attention. Ravi Hira directed our program here, so he gave me a lot of this data since it was kind of a last-minute thing. That's my contact information if you have any questions, and if you have any ideas of how to make our program better, come visit Seattle, but just in the summer, because that's when it's nice.